The chair is bolted to the floor. This is the first thing he notices, not the television mounted on the wall playing a cable news channel with the volume set to a level that is audible enough to prevent silence, but inaudible enough to prevent comprehension, not the vending machine in the corner with the flickering light behind the Doritos, not the intake window where a woman in scrubs is speaking to someone through a circular opening in the plexiglass, the kind of opening that exists in bank teller windows and police stations and emergency room intake desks, the kind of opening designed to facilitate communication while maintaining a barrier between the person who needs help and the person who provides it. He notices the chair. The chair is plastic and metal, and it is bolted to the floor with hex bolts, 4 per chair, the bolts recessed into the concrete in a pattern that someone designed not for comfort, but for permanence. The chairs cannot be moved, cannot be rearranged, cannot be pulled closer to a spouse or a child or an outlet where a phone could charge. The chairs are where they are. The patient sits where the bolts say to sit. His name is Harlan Voss. He is 57 years old. He is the CEO of Pinnacle Health Network, a regional hospital system headquartered in Memphis, Tennessee, that operates 4 hospitals, 12 urgent care clinics, and 6 specialty centers, employs 11,000 people, and generates $2.1 billion in annual revenue. The flagship, Pinnacle Regional Medical Center, is a 580-bed Level 2 trauma center in East Memphis that treats 112,000 emergency department patients per year. The emergency department has 42 treatment bays, 18 physicians, 104 nurses, and a waiting room with 68 chairs bolted to the floor. Harlan came to healthcare from finance. He was a hospital CFO for 12 years before becoming CEO, first at a community hospital in Chattanooga, then at a mid-sized system in Nashville, then at Pinnacle. He understands hospitals the way a CFO understands hospitals, as organisms that consume resources and generate revenue, and that survive or die based on the margin between the two. He reads the balance sheet the way physicians read an EKG, looking for anomalies, rhythms, the patterns that indicate health or decline. He is good at this. The board hired him because he is good at this. Pinnacle was running a 2.3% operating margin when he arrived 7 years ago. Thin, precarious, the margin of a system that was one bad quarter from financial distress. He rebuilt the margin to 4.1%. He renegotiated payer contracts. He consolidated service lines. He closed an underperforming outpatient center and redirected the capital to the cardiac program, which now generates $140 million in annual revenue and is the system's highest performing service line. He rebuilt the margin. He did not rebuild the waiting room. His mother, Peggy, died in a hospital. Not at Pinnacle, at a county hospital in rural West Tennessee 22 years ago, before Harlan was a CEO, before he understood the difference between a margin and a mission. Peggy had chest pain, real chest pain, the kind that starts in the center and radiates to the jaw and the left arm, the textbook presentation that every medical student learns in the first week of cardiology. She drove herself to the hospital because Harlan's father was dead, and Harlan was in Nashville, and the ambulance response time in rural Haywood County was 42 minutes, and the hospital was 14 minutes by car. And Peggy did the math that patients do, the math of urgency, the calculation that says, I can get there faster myself. She arrived at 3:17 p.m. She registered. She sat in a chair. She waited. The emergency department at the county hospital had 8 beds, and 1 physician, and the physician was managing a trauma from a tractor accident, and the trauma took priority because the trauma was ESI level 1, and Peggy's chest pain was triaged at ESI level 2. And the difference between level 1 and level 2 is the difference between now and next in a 1-physician department means whenever now is finished. Peggy waited 47 minutes. At 47 minutes, she had a cardiac arrest in the waiting room. The code team, the 1 physician, 2 nurses, and a tech, responded. They performed CPR. They defibrillated. They intubated. They worked for 28 minutes. Peggy was pronounced at 4:32 p.m. She died in a waiting room, in a chair, 47 minutes after she walked through the door with a textbook presentation of a myocardial infarction that a physician would have recognized in 30 seconds if a physician had been available in the first 30 seconds. Harlan doesn't talk about Peggy at board meetings. He doesn't tell the story at leadership retreats. He carries it the way people carry grief, internally, silently, in the part of the chest that tightens when you walk into a waiting room and see the chairs and count the patients and calculate, without meaning to, how long each one will wait and whether the wait will matter. The wait mattered for Peggy. The wait was 47 minutes. The wait was the difference between a treatable cardiac event and a death in a plastic chair. Harlan has been inside the waiting room before. He has walked through it on board tours, the quarterly visits where the board of directors walks the facilities with the chief medical officer and the chief nursing officer and the facilities director. And the waiting room is always clean when the board walks through because the facilities team knows the schedule, and the schedule is the signal to prepare. He has seen the waiting room at 11 a.m. on a Tuesday, when the census is moderate and the chairs are half full and the intake window has a 2-person queue, and the board members nod and say, "Looks good," and move on to the surgical suite. He has never seen the waiting room at 8 p.m. on a Friday. He is about to. The numbers brought him here. The patient satisfaction scores for the emergency department came back 11 weeks ago, 19%, 19. The national average for emergency departments is 32%, which is itself a damning number, a number that says 2/3 of Americans who go to an emergency room leave unsatisfied, and Pinnacle is 13 points below that. The average wait time from arrival to provider, 4 hours and 43 minutes. The left without being seen rate, the percentage of patients who register, wait, and then leave before a doctor ever examines them, is 14%, 1 in 7. 1 in 7 people who come to the emergency department in a medical crisis walk out the door without treatment because the wait is longer than their patience or their pain or their faith in the system that is supposed to help them. "I need you to see it," said the chief nursing officer, a woman named Lourdes Okoro, who had spent 22 years in emergency nursing before moving to administration, and who retained the emergency nurse's ability to convey urgency without raising her voice. Not the data, not the scores, the room, the people in the room. You need to sit in a chair, a bolted chair, and wait for your name to be called and experience what our patients experience, not for an hour, for the full cycle, from the door to the discharge. If you leave early, you didn't see it. Harlan is wearing jeans, a flannel shirt, and work boots, the clothing of a man who might plausibly present to an emergency department on a Friday night with a complaint that is real enough to require triage, but not acute enough to bypass the queue. The complaint is chest tightness, intermittent, non-acute, the kind of symptom that the triage system categorizes as ESI level 4, less urgent, not a heart attack, not a BD echo, not an emergency that demands immediate intervention. A concern. The kind of concern that brings a 57-year-old man to the emergency room on a Friday night because the tightness has been happening for a week and his wife told him to go and the primary care appointment is 3 weeks out and the emergency room is the only door that's always open. His fake name is Henry North. His fake insurance is a mid-tier PPO. His fake address is an apartment complex in Whitehaven. Only one person in the building knows, the ER medical director, Dr. Kwesi Ampadu, who arranged the cover and who is monitoring the situation from behind the scenes, ready to intervene if a real medical emergency requires Harlan's bed. Tell us in the comments where you're watching from today, because this is the story of a hospital CEO who bolted himself to a chair in his own waiting room, and what he saw in the next 9 hours changed everything. Friday, 8:14 p.m. Harlan walks through the automatic sliding doors of the Pinnacle Regional Emergency Department. The doors open with a hiss, and the smell hits him first, the particular smell of an emergency department, which is not one smell but a composite, hand sanitizer, floor cleaner, the metallic tang of blood that is present even when no blood is visible, the body heat of 68 people in a room designed for 40, and underneath all of it, the ambient human smell of waiting, which is the smell of sweat and coffee and fast food and the specific anxiety that manifests as body chemistry, and that fills a room the way humidity fills a room. You can't see it, but you feel it on your skin. The waiting room is full. Not hospital drama full, every seat taken full, with 12 people standing along the walls and 4 people sitting on the floor. Sitting on the floor. In an emergency department, in a hospital that generates $2.1 billion in annual revenue. People are sitting on the floor because the 68 chairs are occupied, and the floor is the only remaining horizontal surface that isn't a gurney. And the gurneys are behind the locked double doors where the treatment happens, and the treatment isn't happening fast enough for the people in the chairs and on the floor and on the walls to be seen. Harlan walks to the intake window, the plexiglass, the circular opening. Behind the window is a woman in scrubs, badge says Deidre, registration clerk, who is processing a patient ahead of him. Deidre is typing on a keyboard that she doesn't look at because she's been typing on this keyboard for 6 years. And the keyboard is as familiar as her own hands, and the words she types are the same words she types 140 times per day. Name, date of birth, insurance, chief complaint, emergency contact. The patient ahead of him is a man in his 30s holding his left wrist, which is swollen to approximately twice its normal size. The man is answering Deidre's questions with the controlled patience of a person in pain who is trying to be polite to the person processing his paperwork. Because being polite is the social contract of the waiting room. You wait, you answer, you cooperate, and in return, the system promises to help you eventually. Eventually. That word is the emergency department's currency. Everything in the waiting room is eventually. You will be seen eventually. Your pain will be addressed eventually. Your name will be called eventually. The word contains no timeline. The word is a promise with no expiration date, a check with no amount written on it. Harlan registers, name, Henry North. Complaint, chest tightness, intermittent, 1 week. Insurance, verified. He is given a clipboard with forms, medical history, consent, high PEA acknowledgement, the paperwork that every patient fills out and that represents the bureaucratic prerequisite for care, the toll you pay before you're allowed to wait. The forms take 11 minutes. 11 minutes of filling in boxes and checking boxes and signing lines that authorize the hospital to treat him and to bill his insurance and to share his medical information with the people who need it and the systems that store it and the administrators who analyze it. The forms are designed for compliance, not for care. The forms exist because the legal department requires them, and the billing department requires them, and the regulatory framework requires them. And the patient completes them because the patient has no choice. The forms are the price of admission, the ticket to the waiting room, and the waiting room is the ticket to the treatment area. And each ticket must be purchased in sequence with the currency of time and patience and the willingness to cooperate with a system that demands cooperation before it provides care. He hands the clipboard back to Deidre. Deidre takes it without looking at it, not rudely but efficiently, the way a person takes the 100th clipboard of the day. The clipboard indistinguishable from the 99 that preceded it. Deidre is not unkind. Deidre is overworked. Deidre processes 140 registrations per shift, and each registration takes an average of 4 minutes, and the math is 9 hours and 20 minutes of continuous processing, which is longer than her shift, which means the registration stack and the queue builds and the patients waiting to register are waiting before they're allowed to begin waiting. The pre-wait that precedes the real wait, the first of several waits that compose the emergency department experience. He sits, chair 34, bolted to the floor. Between a woman in her 60s who is holding a tissue to a cut on her forehead and a man in his 40s who is coughing into his elbow with the deep, wet cough of a chest infection that has been getting worse for days and that he has waited to address until a Friday night because he works Monday through Friday and his job doesn't provide sick days. And the emergency room is the only option that exists after 5 p.m. for a man who can't miss work and can't afford an urgent care copay. The man coughs. Each cough sends a vibration through the bolted chairs. The chairs are connected by their shared armrests, a continuous row of plastic and metal, and the vibration of one cough travels through the armrest and into the next chair and into the next body. And the man who is coughing is sharing his illness with every person in the row through the medium of the furniture. The bolted chairs don't just restrict movement, they connect bodies. They create a chain of physical proximity that the patients did not choose and cannot change because the bolts are in the floor and the chairs are where the bolts are and the patients sit where the chairs are. Harlan feels the vibration. He feels the cough in the armrest under his left hand. He thinks about infection control, the concept that every hospital administrator discusses in conference rooms and that the waiting room defeats by design. The waiting room places sick people in physical contact with each other for hours. The chairs cannot be separated. The room cannot be rearranged. The patients cannot distance themselves because the bolts have made distancing impossible. The waiting room is, by its fixed geometry, an incubator, a room designed to hold sick people in close proximity for extended periods, which is the precise definition of the conditions that facilitate the transmission of respiratory illness. The clock on the wall says 8:22 p.m. Harlan begins to wait. If this story has touched your heart, take a moment to share it and subscribe to Untold Hearts, because sometimes the person who runs the hospital has never sat in the chair that holds the patient. 9 p.m. Harlan has been waiting 42 minutes. He has not been triaged. The triage nurse, the nurse who performs the initial assessment that determines the severity of the patient's condition and their place in the queue, is one person. One triage nurse for the entire department. Her name is Opal, and she is moving between patients in the order they arrived, conducting assessments that take an average of 8 minutes per patient, and there are 14 patients ahead of Harlan, which means his triage will happen at approximately 10:30 p.m., 2 hours after he walked through the door. Opal is fast. This is immediately visible. She moves between the triage room and the waiting area with the efficient gait of a nurse who has been doing this for years and who has calibrated her speed to the minimum time required for an accurate assessment. She is not slow. The system is slow. One nurse triaging 100 patients per shift is not an understaffing problem. It is a design problem, a structural limitation that was established when the department was built in 2008, and that assumed a patient volume that was 40% lower than the current volume, and that has not been adjusted because adjusting would require a second triage room and a second nurse and a budget line that the CFO has deferred for 3 consecutive fiscal years. Harlan watches the waiting room. He watches because watching is the only thing available. The television is incomprehensible. His phone is at 41%, and there are no outlets within reach of chair 34, and the magazines on the side table are from 2023 and have been read by so many anxious hands that the covers are soft and the spines are broken and the pages fall open to the same articles that no one is reading because no one in an emergency department waiting room reads magazines. They wait. They stare at the television they can't hear. They check their phones. They look at the double doors and calculate, the way prisoners calculate days, the way travelers calculate distance, how much longer. The man with the swollen wrist, the one who registered ahead of Harlan, is sitting 3 chairs down. He has been triaged. His wrist is splinted with a temporary wrap that Opal applied during his assessment. He is categorized as ESI Level 3. Urgent. He's been waiting since 7:48 p.m. It is now 9:15 p.m. An hour and 27 minutes. He holds his wrist against his chest the way a person holds something precious, gently, protectively, with the awareness that the thing he's holding is part of his body, and his body is in pain, and the pain is being managed not by treatment but by time, because time is the only analgesic the waiting room provides. At 9:20, a woman walks in carrying a child. The child is 4 or 5, limp against the woman's shoulder, flushed, eyes half closed. The woman's face is the face of a parent whose child is sick, not the composed concern of a routine illness, but the elevated electric alertness of a parent who is calibrating between fear and function, between the instinct to scream and the requirement to register. She goes to the window. She speaks to Deidre. Deidre types. The woman is told to sit and wait for triage. The woman looks at the waiting room. Every chair is full. She looks at the floor. People are sitting on the floor. She looks at her child, limp, flushed, heavy against her shoulder. And she looks at the floor, and she does what mothers do. She sits on the floor with the child in her lap, her back against the wall, and she waits. A hospital CEO's child would not wait on the floor. A board member's child would not wait on the floor. the chief medical officer's child, would not wait on the floor. But this woman's child, this child whose mother has a mid-tier insurance card and a Whitehaven zip code and a body that is too small to sit in a bolted chair and too sick to stand, this child waits on the floor because the floor is what the system provides when the chairs run out. If you're enjoying this story, hit that like button right now. It takes 1 second, costs nothing, and tells us to keep making stories like this one. Back to the story. 11 p.m. Harlan has been waiting 2 hours and 38 minutes. He has been triaged. Opal assessed him at 10:22, checked his vitals, asked about the chest tightness, categorized him as ESI level 4. She was professional, thorough, and fast. She also looked tired, the particular tiredness that isn't sleepiness, but depletion. The systematic draining of a person who has been making rapid clinical decisions for 6 consecutive hours, and who will continue making them for 6 more, and who is doing the work of 1 nurse in a system that needs 2. The woman with the child was triaged at 9:45, ESI level 3. The child has a fever of 103.4. The child has been in the waiting room for 25 minutes. The child has been in the waiting room for 25 minutes with a fever of 103.4 and has not been given medication because medication requires a physician order, and the physician is behind the double doors treating the patients who were ahead of the child in the queue. And the queue is the queue. And the queue does not account for the fact that a child with a 103.4 fever should not be sitting on a floor waiting for a doctor who is treating the 23 patients ahead of her. Harlan has watched 3 people leave. 3 people who registered, waited, and walked out. The first left at 9:50. A man in his 20s who had been waiting since 7 p.m., 2 hours and 50 minutes, who stood up, walked to the intake window and said, "I can't do this. I'll go to urgent care tomorrow." He walked out. Deidre noted it in the system. LWBS, left without being seen. The code that the hospital tracks as a metric and that the patient experiences as a surrender. The second left at 10:15. A woman with abdominal pain who had been waiting since 6:30. 3 hours and 45 minutes. She didn't tell Deidre. She just stood up and walked through the automatic doors and disappeared into the parking lot in the night and the gap between what the hospital promises and what the waiting room delivers. The third left at 10:40. An older man, 70s, thin, wearing a coat despite the warmth of the overcrowded room, who had been sitting in the same chair since before Harlan arrived. He left slowly. He stood with the care of a person whose body makes standing an engineering project. He walked to the door with the particular gait of surrender, not angry, not frustrated, just done. The way a person is done when the system has exhausted not their patience, but their belief that the system works. 3 people in 2 hours. 3 people who came to a hospital for help and left without receiving it. 3 people who are now at home, or in a car, or in a bed, managing their own symptoms because the system that is supposed to manage their symptoms asked them to wait longer than their faith could hold. If Untold Hearts has become part of your week, consider joining the channel membership. A few dollars a month keeps these stories coming. Links are in the description. Now, back to the story. 1 a.m. Harlan has been in the waiting room for 4 hours and 46 minutes. His name has not been called. He has watched the waiting room cycle. Patients arrive, patients are triaged, patients wait, patients are called, patients leave without being seen. The cycle is relentless. The cycle does not pause for shift changes or meal breaks or the specific exhaustion of the nurses and clerks and technicians who run the cycle. The cycle runs the way machines run, continuously, mechanically, with human beings as the moving parts. The waiting room at 1 a.m. is a different room than the waiting room at 8 p.m. At 8 p.m., the room is full of the recently arrived, people whose pain is fresh, whose patience is intact, whose faith in the system has not yet been tested by the hours that test it. At 1 a.m., the room is full of the survivors, the people who have been here for 3, 4, 5 hours, and whose faces have undergone the transformation that extended waiting produces. The muscles relax, the posture softens, the eyes develop the flat focus of people who have stopped looking at the double doors because looking at the double doors is a form of hope, and hope requires energy, and 5 hours of waiting has consumed the energy that hope requires. Harlan has counted the departures. 7 people have left without being seen since he arrived. 7. The first at 9:50, the last at 12:35. 7 people who registered and waited and then calculated, the way all patients eventually calculate, that the wait exceeds the value of the treatment, that going home untreated is preferable to sitting for another hour in a bolted chair under fluorescent lights watching a television. Nobody can hear while the double doors open for other people's names and never for yours. The 7th was a woman with a laceration on her forearm, a cut that was bleeding through the gauze she'd wrapped around it at home, and that needed stitches, and that she'd waited 3 hours and 10 minutes to have stitched, and that she decided at 12:35 a.m. to manage herself. She left. She went home. She will either clean the wound and butterfly it and hope it heals without infection, or she will come back tomorrow, or she will go to an urgent care that opens at 8 a.m. and that charges a $40 copay that her insurance requires and that she didn't want to pay, which is why she came to the emergency room in the first place, because the emergency room cannot turn you away for inability to pay, and the urgent care can, and the emergency room is the safety net, and the safety net has a 9-hour wait, and the 9-hour wait is the price of the safety net that nobody tells you about when they tell you the emergency room is always open. The woman with the child is still here. The child is sleeping in her lap, the fever sleep of a small body fighting an infection, the sleep that is not rest but the body's withdrawal from a fight. It's too tired to continue while awake. The woman has not moved. She's been sitting on the floor for 4 hours. She has not eaten. Relief that the hospital provides. The relief that the hospital provides, the physician, the medication, the treatment, has not arrived. At 12:50, a custodian comes through the waiting room. He's pushing a mop bucket, the yellow industrial bucket with the ringer, the universal symbol of institutional cleaning. He mops around the chairs. He mops around the people on the floor. He doesn't ask them to move. He mops around them, the way you clean around furniture, the way you work around objects that are fixed in place. The patients are furniture. The patients are objects in the path of the mop. The custodian is not unkind. He is doing his job, and his job is to clean the floor, and the floor has people on it, and the people cannot be moved because the people have nowhere to go. He mops around them, and he moves on, and the floor is clean, and the patients are still there, and the system has maintained its hygiene and its indifference simultaneously. A nurse opens the double doors. North? Henry North? Harlan stands. 4 hours and 46 minutes. The nurse leads him through the double doors into the treatment area. The treatment area is a different world, not a different building, but a different experience. Behind the double doors, the hospital is active, clinical, purposeful. Nurses move between bays, monitors beep. The overhead lighting is bright and clean. The air smells like antiseptic and efficiency. The waiting room smells like anxiety and stale coffee. The double doors are the border between the 2 countries that exist inside every emergency department, the country of treatment and the country of waiting. And the border crossing takes 4 hours and 46 minutes. He is placed in Bay 22, a curtained bay with a gurney, a monitor, a chair, and a wall-mounted computer. The nurse, badge says Clarice, RN, takes his vitals, connects the monitor, asks the same questions Opal asked 3 hours ago. The repetition is the system. The system requires verification at every handoff, the documentation that ensures continuity, and that also ensures that the patient tells the same story multiple times to multiple people who type the same words into the same system, the bureaucratic redundancy that exists for safety and that feels, from the gurney, like nobody is listening. Dr. Ampadu arrives 12 minutes later. He performs the examination, listens to the chest, palpates the abdomen, reviews the vitals, orders an EKG and blood work. He is professional and thorough, and he does, in 12 minutes, the work that Harlan has been waiting 4 hours and 46 minutes to receive. 12 minutes. Harlan lies on the gurney and processes this number. 4 hours and 46 minutes of waiting, 12 minutes of medicine. The ratio is 23-1, 23 minutes of waiting for every 1 minute of care. This is the ratio that every emergency department patient experiences and that no hospital advertises and that the waiting room enforces with its bolted chairs and its locked doors and its television set to a volume that communicates, You are not forgotten, but you are not next. The EKG takes 4 minutes. The blood draw takes 3. The results take 47 minutes. The lab processing time, the queue within the queue, the secondary waiting that happens inside the treatment area, and that is invisible from the waiting room. But that extends the total time in the building by the duration of the lab's workflow. Harlan lies on the gurney during the 47 minutes. The gurney is more comfortable than chair 34. This is not saying much. The gurney is a vinyl-covered platform with a paper sheet designed for clinical access rather than patient comfort. But the gurney is horizontal, and the chair was vertical, and after 5 hours of sitting upright in a bolted chair, the body's gratitude for a horizontal surface is the gratitude of a desert for rain. The curtain to his left is partially open. In Bay 23, a woman is being treated for an allergic reaction. Hives, swelling, the visible symptoms of a body fighting something it has encountered and rejected. A nurse is administering epinephrine. The treatment is quick and decisive, and the woman's symptoms are resolving in real time. The swelling subsiding, the hives fading, the body responding to the medicine with the immediacy that medicine provides when medicine is available. The woman arrived by ambulance. She bypassed the waiting room. She went from the ambulance to the bay in 4 minutes. The emergency was acute. The system responded. The curtain to his right is closed. Behind it, Harlan can hear a conversation, a doctor speaking to an elderly man about chest pain. Real chest pain, not the intermittent tightness of Harlan's cover story. The doctor's explaining the results of a cardiac enzyme test. The words are careful, measured, the vocabulary of a physician delivering a serious diagnosis with the calibrated honesty that medical training develops, and that the patient receives with the specific silence of a person hearing news that changes the trajectory of their life. Harlan thinks about Peggy. He thinks about Peggy in the chair at the county hospital, waiting 47 minutes with textbook chest pain, waiting while the one physician managed a trauma, waiting because the system had one physician and the one physician was occupied, and next was not fast enough. He lies on the gurney in Bay 22 and listens to the doctor behind the curtain explain a cardiac diagnosis to a man who is alive because the triage nurse recognized the severity and escalated. And the system worked for that man. The system caught his emergency in the triage room and moved him to the front of the line. And the system is working. The system works. The system is designed to prioritize the most critical cases, and it does prioritize them. The problem is not the priorities. The problem is the capacity. The problem is that the system can prioritize the critical cases and cannot simultaneously serve the non-critical cases, and the non-critical cases wait and wait and wait, and some of them walk out, and some of them get worse while they wait, and the system does not see this because the system is behind the double doors, and the waiting room is not. The wait, Harlan says. How long is normal? Ampadu looks at him. The look is the look of a doctor who knows the CEO is in the bay and who is choosing his words with the precision of a surgeon choosing an incision point. Normal is 4 to 5 hours for ESI 4. On weekends it can be 6 or 7. The record is 11 hours and 14 minutes. A woman with chronic back pain who waited in the waiting room from 4 p.m. to 3:14 a.m. She was seen, treated, and discharged at 4 a.m. She spent 12 hours in this building. 11 of those hours were in a bolted chair. What's causing it? Volume and staffing. We see 300 patients a day. We have capacity for 220. The gap, 80 patients a day, is the overflow that fills the waiting room and creates the wait time. We need more beds. We need more nurses. We need more physicians. We need a second triage nurse. We need a fast-track system for ESI 4 and 5 patients, a parallel track that takes the low-acuity patients out of the main queue and into a dedicated area where they can be seen in under an hour instead of under 5. Every emergency department in the top quartile has a fast track. We don't. I've submitted the proposal 4 times in 3 years. What happened to the proposal? The CFO deferred it. 3 consecutive fiscal years, deferred to next fiscal year. The same phrase every time. The fast-track build-out costs $1.2 million. The annual operating cost is $800,000. The revenue from the LWBS patients we lose, the 14% who walk out, is estimated at $3.4 million annually. Patients who leave without being seen don't generate revenue. They do generate liability. They do generate bad outcomes. The ones who go home and get worse, the ones who don't come back, the ones who die from the thing they came in for but didn't wait long enough to have diagnosed. Harlan lies on the gurney. The monitor beeps. The EKG is normal. His chest tightness is real but benign, the product of stress and age and the particular cardiac awareness that develops in men over 50 who have fathers who died of heart conditions and who interpret every flutter as a message from the genetics they can't outrun. He is discharged at 2:40 a.m. He has been in the hospital for 6 hours and 26 minutes. 4 hours and 46 minutes of that was waiting. 12 minutes was the examination. Is 2:40 a.m. The room still has is 2:40 a.m. The room still has 31 people in it. The bolted chairs, the flickering vending machine, the television. The woman with the child is gone. She was called back at 12:15 a.m., 4 hours and 55 minutes after she arrived with a child who had a 103.4 fever. The floor where she sat has a stain from a juice box the child drank during the wait. Nobody has cleaned it. Nobody will clean it until the morning shift because the night custodian covers 3 floors and the waiting room floor is not a priority. And in chair 14, there is a man, 70s, gray hair, thin. He is wearing a hospital gown under a coat, the gown he was given during a previous visit, the coat he came in with. His chart, Harlan checks the registration screen on his way past Deidre's window, shows arrival time, 5:48 p.m. It is now 2:42 a.m. He's been waiting 8 hours and 54 minutes. Harlan stops. He looks at the man. The man is staring at the double doors, not with anger, not with impatience, with the particular emptiness of a person who has been staring at the same doors for 9 hours and whose stare has burned through frustration and anger and resignation and has arrived at the far side of waiting, which is not patience, but absence, the absence of belief that the doors will open, the absence of faith that his name will be called, the absence of the conviction that walking into this building was the right decision. The man stands, slowly, the way a 70-year-old stands after 9 hours in a plastic chair bolted to the floor. He picks up his coat. He walks to the automatic doors. The doors open with a hiss. The man walks through them, walks into the parking lot, into the night, into the gap. He doesn't tell Deidre. He doesn't tell anyone. He just walks out. 9 hours, no name called, no doctor, no treatment. He came to the hospital because something was wrong, and the hospital asked him to wait, and he waited for 9 hours. And then he walked out. Because 9 hours is the limit, not the limit of his patience, the limit of his dignity, the limit of the human capacity to sit in a bolted chair and believe that someone on the other side of a locked door remembers you exist. LWBS. Left without being seen. Another code, another metric, another person. The leadership meeting is Monday morning. Harlan walks in carrying a hex bolt. A single hex bolt, the kind that holds the chairs to the floor of the waiting room. He took it from chair 34 with a socket wrench at 3 a.m. on Saturday morning. He sets the bolt on the conference table. Then, "This bolt holds a chair to the floor of our waiting room," he says. "The chair can't move. The patient can't move the chair closer to a family member, can't move it to an outlet, can't rearrange the room when it's full. The bolt is a design choice. The design choice says, you sit where we tell you to sit, and you wait for as long as we make you wait, and you cannot change anything about this experience except your decision to stay or leave." He looks at the room. The CMO, the CNO, the CFO, the VP of operations, the department heads. Lord Okoro, the CNO, is sitting with her hands folded and her face doing the thing that faces do when someone in power finally sees what you've been describing for years. I sat in chair 34 for 4 hours and 46 minutes on Friday night. I was triaged by one nurse who was doing the work of 2. I was seen by a doctor who spent 12 minutes on an exam I waited 5 hours for. I watched 3 people walk out without being seen. I watched a woman sit on the floor with a sick child because every chair was full, and I watched a man wait 9 hours, and then stand up and walk out. He pauses. The room is silent. Lord Okoro, the CNO, is sitting with her eyes closed, not because she doesn't want to see, but because she's been seeing this for years, and hearing it from the CEO's mouth is both a validation and a grief. The grief of a person whose warnings have been confirmed by the person who had the power to prevent the need for warnings. That man, the one who walked out after 9 hours, I don't know his name. The registration system has his information, but the registration system also has a code next to his entry. LWBS, left without being seen. That code is what our system generated for a man who gave us 9 hours of his life on a Friday night when he could have been home, could have been resting, could have been doing anything other than sitting in a plastic chair bolted to the floor of a building that employs 11,000 people and generates $2.1 billion in revenue, and that could not, in 9 hours, find 12 minutes for him. He looks at the CFO, a man named Truitt, who has deferred the fast-track proposal 3 times and who is looking at the bolt on the table the way a defendant looks at evidence. I know the numbers, Harlan says. I know the margins. I rebuilt the margins. I consolidated service lines. I closed the outpatient center in Germantown. I have spent 7 years optimizing the financial performance of this system, and I have succeeded, and the system is financially healthy, and the waiting room is broken, and the financial health and the broken waiting room exist in the same building and the same budget cycle, and I have been prioritizing the wrong one. He picks up the bolt. The fast-track proposal that Dr. Ampadu has submitted 4 times, approved. The $1.2 million build-out starts in 30 days. A dedicated fast-track for ESI 4 and 5 patients, seen in under an hour. The 14% LWBS rate represents $3.4 million in lost revenue annually. The fast-track pays for itself in 5 months. Second triage nurse, hired within 2 weeks. The single-nurse triage model was designed for a patient volume that no longer exists. 2 nurses, 2 rooms, parallel triage. The wait from door to triage drops from 2 hours to under 30 minutes. Waiting room capacity expanded. The adjacent storage area, a room that holds outdated equipment and the filing cabinets from the 2019 records digitization, is cleared and converted. 40 additional seats, not bolted to the floor, movable chairs, chairs that a mother can pull next to a wall outlet, chairs that a husband can move next to a wife, chairs that treat the patient as a person who can arrange their own comfort, not a body that sits where the bolt says. Charge nurse in the waiting room, a dedicated nurse stationed in the waiting room during peak hours, 4 p.m. to 2 a.m., whose job is not triage, not treatment, but presence. The nurse checks on waiting patients, distributes water, takes vitals on patients whose wait exceeds 2 hours, provides updates, answers questions. The nurse is the face of the hospital in the room where the hospital currently has no face, just plexiglass and a circular opening and a television nobody can hear. And the 9-hour rule. No patient waits longer than 4 hours without a physician touchpoint. If the wait exceeds 4 hours, a physician goes to the waiting room, reviews the patient's chart, performs a bedside assessment, and either treats in the waiting room or escalates to a bay. No patient sits in a bolted chair for 9 hours without a doctor seeing them. The system does not allow it. The system allowed it before because nobody in the boardroom had sat in the chair. Someone has now. I'm going to keep this bolt on my desk, Harlan says. Every time we make a decision about this hospital, I'm going to pick up this bolt and ask, would I make this decision if I were sitting in the chair it holds down? 3 months later, Friday night, 8 p.m. The fast track is open. The ESI 4 and 5 patients, the chest tightness, the chronic back pain, the cough that's been getting worse, the sprained ankle, the rash that won't go away, are routed to a dedicated 6-bay area staffed by 2 physicians and 3 nurses. The fast track sees patients in an average of 44 minutes, down from 4 hours and 43 minutes. The patients who used to wait 5 hours for a 12-minute exam are now seen in under an hour and treated and discharged and home before the old system would have called their name. The LWBS rate dropped from 14% to 4.8%. Still too high, 4.8% is still 1 in 20, still patients walking out the door. But the trajectory is downward, and the gap is closing, and every percentage point represents human beings who stayed and were seen instead of surrendering and leaving. The waiting room has been expanded. 108 seats, movable seats, cushioned, with armrests and outlets at every fourth chair. The floor space that was occupied by bodies sitting on tile is now occupied by chairs that can be moved, that can be clustered, that can be arranged by the people who sit in them according to the needs of the people who sit in them. A mother with a sick child can pull a chair next to an outlet and charge her phone while she waits. A husband can sit next to a wife. A 70-year-old man can sit in a cushioned chair instead of a plastic one. The charge nurse is in the waiting room. Her name is Benita, a 20-year ER nurse who transferred from the treatment area because, she said, the patients in the bays have nurses. The patients in the chairs don't. Benita walks the room. She checks vitals. She distributes water. She crouches next to patients and asks, "How are you doing? Do you need anything? Your estimated wait is approximately 40 minutes. The information, the estimated wait, is the thing that changes everything, not the wait itself. The information about the wait, because a person who knows they will wait 40 minutes waits differently than a person who doesn't know if they'll wait 40 minutes or 9 hours. The information converts the waiting from endurance to expectation, from suffering into planning, and the human capacity for planning is infinite, while the human capacity for endurance has a limit, and the limit is approximately 9 hours in a bolted chair. Harlan comes to the ER every month, not as a patient, as a chair. He sits in the waiting room from 8 p.m. to midnight. He doesn't identify himself. He sits in a movable chair, and he watches, and he counts the patients and the nurses and the minutes, and he measures the distance between the hospital he runs and the hospital the patient experiences, because the distance is always there. It's smaller now, it's closing, but it's there, and the only way to see it is to sit in the chair and wait. The bolt is on his desk. Next to it, taped to the wall, is a printout from the registration system showing an entry from that Friday night. A patient, male, 70s, arrival time 5:48 p.m., status LWBS, time 2:42 a.m., 8 hours and 54 minutes. No name, no treatment, no diagnosis, just a code, LWBS, and a timestamp in the empty space where a medical record should have been. Below the printout in Harlan's handwriting, he waited 9 hours. We owe him more than a code. Thank you for watching this story. If it reminded you that a hospital waiting room is not a room where people wait, it's a room where people decide whether the system works, share it. Subscribe to Untold Hearts for more stories about the chairs we ask people to sit in and the time we ask them to give. Tell us in the comments, what's the longest you've ever waited in an emergency room?